because now we have a second patient, 68-year-old female, also doesn't have cirrhosis, has this LR5 lesion up here. It's measuring 46, 47 millimeters up here in the segment 7, right along the liver capsule area. Thermal ablation still an option, or
did they get a biopsy?
This one is also biopsy-proven HCC.
Just because no underlying cirrhosis, our practice is to get a biopsy. You can't assume that it's going to be HCC in a non-cirrhotic. So this is well beyond most ablation guidelines, including ours. While a thermal ablation is technically feasible, the recurrence rates are sky high once you start getting above 3 centimeters. In our series that my colleagues published, the recurrence rate after a thermal ablation is about 15 to 20% at 1 year. So to me, that's pretty high when you compare it to, let's say, if you can do a partial right hepatectomy and you get an R0 margin, your recurrence rate is probably in the single digits or even less, right? So my preference would be to see if you can do a partial right hepatectomy.
Wow, thanks, Ed.
See, that would be my conversation with the patient. Say, go see our surgeons first.
Yeah, I agree with that. I think that's at least from what we see, very amenable to surgical resection. I think that's the best option for a tumor that size. And I know that, Adam, you had a study open that looked at adjuvant in this setting, right? That would meet the criteria for size. I can't recall exactly, but
the cutoff for most of the adjuvant studies was 5 centimeters. So, on the resection tissue, it could be a bit bigger, depending on what that would be the size that we would use. Adjuvant data is still coming. That study that we were participating in actually has not read out yet, but others have. The kind of most press has come from the IMbrave 050 study, which on its initial data analysis did look like there was an improvement in recurrence rates for those patients treated with adjuvant atezo-bev for a year versus those who were surveyed. Unfortunately, subsequent data analysis has been less promising, and it looks like those curves are mostly overlapping at this point. So I don't know that adjuvant atezo-bev is going to be the answer for such patients, but as I mentioned, there's other ongoing studies that are large phase 3 studies looking at different combinations of adjuvant immunotherapy that may have some promise.
But if this patient was, let's say they refuse surgery again, right? Like the first one. From a local regional therapy standpoint, while ablation to me is off the table, it's easily amenable to a radioembolization, right? So this would be most likely a straightforward Y90, and in our series of patients with 5 centimeter tumors or less, we're looking at objective response rates in excess of about 96, 97%.
Yeah. So Gabe and your colleagues won this battle, I should say, and she ended up going for a right posterior sectorectomy, and she did quite well for 6 years until she eventually developed a recurrence. And this is what the recurrence looks like. Unfortunately, not a transplant candidate due to concurrent alcohol use, and has expressed a strong interest to not stop drinking. So now we have this 26 millimeter recurrence, knowing that she did have a previous surgery. What's our thought process here? Would you repeat surgery?
If she still, despite her best efforts, has no cirrhosis, I think that's amenable to resection as well. And it's a smaller tumor, a little bit more painful on the surgical end with her previous hepatectomy, but I think it's definitely feasible considering it's on the contralateral side. And yeah, I think you can get away with doing it without taking too much liver. So I think that would be an option still.
And if she wanted to explore alternatives, what about the location for thermal ablation?
So I think that the biggest concern from a location standpoint comes due to its proximity to the stomach. This is a single slice, so it's one of those where you have to really kind of study it both in axial, coronal planes, et cetera. From a thermal ablation standpoint, I still think it's safe. If we were too close, this would probably be a relatively straightforward hydrodissection where we could put a small needle in between that segment 2 and the stomach and instill half a liter of fluid, and it should be fine. That being said, I think either a thermal ablation or a segmental radioembolization would be potentially, get us a complete response in this case in greater than 90% of the time. So I think it ends up being dealer's choice.
Okay. And how about now with recurrence? Are we starting to talk transplant yet? Or are we still...
Well,
assuming she would ever stop drinking?
Right, exactly. We led with that. So again, the fact that she is not cirrhotic and there are other options with potential curative outcomes, we would not pursue transplant.
Gabe, question for you. Do you worry about continuing to chip away at someone's liver like this that is still drinking? She's thankfully not cirrhotic now, but obviously at risk.
Yeah, definitely. I think the more liver you take out, the more at risk she becomes. I think that's a bit of a challenge, right? Because if they're not taking care of themselves and doing what they need to do to prevent their, disease progression, it gets very frustrating to be chipping away at a problem that's just going to keep popping up. Because once you have one recurrence, the odds of getting a second recurrence, it goes up substantially. So it's a good point, and definitely frustrating, and really you got to have real heart to heart, I think, with patients like this.
And probably say to the hepatologist, like, why don't you get this under control?
Right. Darn you, hepatologist. Awesome.
This patient chose to go with radioembolization. We didn't feel that the stomach would be very easy to hydrodissect away. And ended up having a complete response and is doing well to this day.